When you are treating adults with either braces or Invisalign, there are sometimes some limitations, and there are some traps you can fall into. This is an adult who came in who has lower spacing and rotations, and upper crowding and rotations. She came to me, I guess, having had Invisalign in the past. You see the attachments on the teeth. So let me show you each arch, and let me show you the trap that you have to be careful with. Making these teeth properly aligned, there's no trap at all in that. Very easy for braces or Invisalign to line up these teeth as you see on the screen. The lower teeth, even easier to retract and close the space and line up the teeth. So this may indeed be the patient's chief complaint, either the crookedness of the upper teeth or the spacing of the lower. But here's the trap that you have to watch for, and that's why you plan this out in the beginning. One of the clues to the trap is that the molar relationship is an end-on class 2 bilaterally. In fact, even more than end-on. So we'll call it a not full class 2, but almost full class 2. A patient with a full class 2 bilaterally should have about 6 millimeters overjet, maybe in this particular case 4 to 5 millimeters. But this patient has no overjet. Her teeth are touching nicely. However, when you bring the lowers back and you move the upper forward, you are going to develop overjet. You are revealing the true position of the mandible. You're revealing the underlying class 2 discrepancy. Over time, the teeth have moved in a certain way that compensated for that. The lower teeth have come forward over time. The upper teeth have retracted back to give you a sense of a proper anterior relationship. But when you address each arch individually, you then reveal the latent class 2. Now, I've treated patients like this in the past, more so when I was younger and I didn't want to take risks. 50% chance, in my opinion, this patient is going to love her teeth and function fine. But another 50% of the patients will detect or feel like they have an overbite, because the lower teeth being forward will mask a little bit that overjet. And then when you create that, they're going to have a sense that their upper teeth are isolated. These upper teeth may look flared to you, but if you brought this patient's lower jaw forward, that angulation isn't too bad. So I'm going to repeat that. These upper teeth appear like they are flared forward, but if the lower jaw came forward, they would not appear that way, even if they remained at that angulation, because they wouldn't be as isolated forward and you wouldn't have that overjet. Now, you can address this case and treat it just like I did here, and then do a surgical advancement of the lower jaw, but the patient very well may not want to go through that kind of procedure. This patient is in her 60s, I believe. If this was a child, you could treat it this way, and they would wear rubber bands or a mandibular advancement appliance and maybe grow out of that class 2. So this is a case you have to proceed with caution. If you're experienced, you may be thinking, hey, can you do some upper IPR to bring these teeth in a little bit more than this? And the answer is yes, but it won't reduce the overjet that much more. And you're still going to have that risk that the patient is going to sense that they have an overbite at the end of the treatment that they were not aware of or didn't even have at the start.